Good morning, everyone. Thank you, and welcome to another NCLEX review. My name is Alexandra. We're just going to give 2 more minutes for the rest of our classmates to get logged in. Then we're going to do a brief recap of what we learned last class, which is we learned how to interpret EKG rhythms, we learned normal sinus rhythm, sinus brady, sinus tach. We also learned the difference between atrial fibrillation and atrial flutter. So we'll just review those briefly and then we'll continue on in learning the other EKG rhythms so that we can work towards finishing cardiac by next class. So let's just give 2 more minutes to our classmates and then we will get started. Thank you. All right, everyone. So last class we learned how to interpret an EKG. So remember, a rhythm is either sinus or not. So the first step is to determine if the rhythm is sinus. The rhythm is sinus if there is a P wave in front of every QRS and the rhythm is regular, which means all the QRSs are always the same distances apart. So if the answer for both of those is yes, you're going to count your 30 boxes, which will give you 6 seconds. Then you count your QRSs and multiply by 10. This will give you your heart rate. It's sinus rhythm if it's 60 to 100, sinus brady if it's less than 60, sinus tachy if it's greater than 100. So we learned normal sinus rhythm. So basically in this EKG strip, we had analyzed that there's a P wave in front of every QRS. The QRSs are all the same distance apart. We counted the QRSs 1, 2, 3, 4, 5, 6, 7. So that means the heart rate is 70 and this is normal sinus rhythm. Then we looked at sinus bradycardia last class. So there is a P wave in front of every QRS. The QRSs are the same distance apart every time. We counted the QRSs 1, 2, 3, 4. The heart rate is 40. This is sinus bradycardia. And we talked about sinus bradycardia and we talked about how you only have to treat sinus bradycardia if it is symptomatic. And we learned that the first line drug of choice for the treatment of symptomatic bradycardia is atropine IV push. Then we talked about sinus tachycardia. So there is a P wave in front of every QRS. And then we counted the QRSs 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So the heart rate here is 130. And the tip that I gave you for sinus tachycardia is to first, after you know the heart rate, then you check the blood pressure. And if the heart rate is high and the blood pressure is low, the patient probably needs fluids. If the heart rate is high and the blood pressure is high, and you communicate that with the healthcare provider, they may order a beta blocker because that would help stabilize both. Then we talked about atrial fibrillation or AFib. So we talked about how this is not a sinus rhythm. Okay, there is not a P wave in front of every QRS. Actually, you cannot identify a P wave. Okay, hold on. Some students are having trouble. Hold on 1 second, everyone. Some students are having. So we learned about atrial fibrillation. There are no discernible P waves here. Actually, these scribbles that you see are fibrillatory waves, and these are very chaotic and unorganized in appearance. And so also this is not regular because the QRSs, their distance from each other, it varies, right? So in the beginning, you see the first QRS to the second, that's one distance. From the second to the third, you can see the third one comes closer than it should. From the third to the fourth, that comes even closer. And then from the fourth to the fifth, that's another distance. So because the distances between the QRS intervals differ, this is not a sinus rhythm. This is atrial fibrillation. Remember, we learned the treatment for atrial fibrillation. It includes diltiazem. It also includes a beta blocker like metoprolol or propranolol. Also, we can do cardioversion, which is like a lower level of electricity than defibrillation, and also we can do ablation. Okay. Also, remember, a patient with atrial fibrillation is at higher risk for blood clots, so that's why they're usually on warfarin and Coumadin to prevent stroke and blood clots. Then we have atrial flutter. So atrial flutter is a lot more organized in its appearance. So let's take a look at the two. So you see atrial fibrillation at the top is more disorganized. And with the fibrillatory waves, with atrial flutter, you see the F waves, which look like shark teeth. And we call it, yes, the F waves or the flutter waves. And what you do is you count how many F waves are in front of the QRS. And that's how many times the electrical conduction circled around. It's an abnormal circuit pathway in the atria that cause those F waves to appear. And however many times that circuit has to circle before it jumps to the AV node is the conduction rate, right? So here, this is a T wave, so don't confuse that. So now here, 1, 2, 3, then you get a QRS. So that means this conduction rate is 3 to 1. That abnormal electrical pathway had to circle around 3 times in the atria before the conduction jumped to the AV node to then eventually result in the QRS. So you don't have to know that for NCLEX, but it's just very important to know the difference in what atrial fibrillation looks like and atrial flutter. Remember, anytime you see the word fibrillation, I want you to think scribble. Fibrillation, scribulation. It's like scribbles up here. And atrial flutter is very organized in appearance. The treatment for both of them are the same. Diltiazem, a beta blocker. They need Coumadin long term for blood clot prevention. They both could benefit from cardioversion. If both of them are severe or recurrent, the doctor may want to consider ablation. However, just know that atrial flutter is more resistant to medication. So, whereas atrial fibrillation is more likely to resolve with medication, atrial flutter probably may not resolve with medication and may require ablation. Next up is supraventricular tachycardia. Supraventricular tachycardia, I want you to write this down. What I highlighted here, please write this down. You have to know this for the NCLEX. Ladies and gentlemen, you have to memorize this for SVT for the NCLEX. So please write down what is highlighted and make sure you memorize that while you're studying this week. Supraventricular tachycardia. For SVT, I want you to think of the S's. For SVT, I want you to think of the S's. SVT is super skinny, it's super fast, and we treat it with adenosine, and you have to give adenosine by slamming it fast in the AC or higher, and it stops the heart. SVT, I want you to think of the S's. It's super skinny in appearance. It's super fast because it's a tachycardia, supraventricular tachycardia. You treat it with adenosine. There's an S in it. How do you give adenosine? You have to slam it in an IV very fast. That means you give it IV push very fast. And it has to be in the AC or higher. So in the antecubital region or higher. You can't give it in the hand. You have to give it in the AC, because if you give it lower than the AC, by the time the medication gets to the heart, it will no longer be effective. And the way that it works is that it stops the heart. So you definitely want your patient laying down when they receive this medication. Okay, so the way that it works, and let me use the tool. So, okay, so we see these first 4 beats, right? Because anytime you see, well, actually, this is the beginning of the problem. So we have 3 normal beats here. And remember, anytime you see PQRST, PQRST, PQRST. So PQRST, this is one heartbeat, right? The P wave is the atria have contracted, then the QRS is the ventricles contracted, and then the T wave is the ventricles relaxed, and then it's going to begin all over again. So this represents one full heartbeat, right? So 1, 2, 3 normal heartbeats, and then we have a sudden onset of SVT. So the differences. So can you tell me what is the difference? I'm going to circle both. I'm going to circle a normal heartbeat, and then I'm going to circle the first instance when SVT began, and I want you to tell me the difference. Okay, so what is the difference between the normal heart rate in green, or the normal heartbeat in green, and the sudden onset of SVT, which I circled in red? What is the difference in appearance? Very good. Very good. Nurse Jean, very good. There's no P wave. And let me remove the circles if that helps you, right? So just compare. There's no, the P wave is gone, right? So look at the name, supraventricular tachycardia. This is an issue that has occurred above the ventricles and it has caused the ventricles to respond by beating too fast. So does it make sense that the P wave is gone now because it's like the ventricles took over? That's why the P wave is gone. Also, as you can see, because of the fast rate, don't you see that the QRSs have become more skinny? SVT looks very skinny. It's super fast. So this is a very narrow, complex QRS tachycardia. Okay? So narrow, complex QRSs mean they're very skinny. Narrow, complex. They're very skinny. The heart rate is usually 150 to 200. The symptoms may include palpitations, feeling faint, sweating, shortness of breath, or chest pain. So last thing, remember your S's. For SVT, remember your S's. It's super skinny. It's super fast. You treat it with adenosine. How do you give the adenosine? You have to slam it. You have to give it IV push very quickly. Can you give adenosine in the hand? If the patient only has an IV in the hand, can you give it? No. Sometimes in the emergency room, when they get desperate for IVs, they put an IV in the foot. Can you do that with adenosine? Will it work? I don't know why the Zoom link is acting up, everyone. I'm so sorry. Everyone is texting me that they can't get in the Zoom, but so far I've texted the people who have had issues the Zoom link and they were able to get in. Can you tell me, can you give exactly? No, you cannot give IV adenosine anywhere other than an AC or higher, okay? Hold on, another student. I don't know what's going on because I didn't change the Zoom link. It's the same Zoom link it's always been. Anyways, the AC, can you tell me where is your AC? Where is your antecubital region? Is it at the bottom of your arm, in the middle? Is it in your upper arm? Where is the antecubital region? In the middle of the arm. Very good. And it's in the middle of the arm. So it's in the bend of your arm, right at the middle. So like your elbow is underneath it. So it's on top of your elbow, basically. That's the antecubital region. That or higher is how you can give adenosine, and you give it quickly. And the reason why you have to give it in the AC or higher is it because it will become ineffective very quickly. So if you give it any lower than the AC, by the time it reaches the heart, it won't work anymore. And it works by stopping the heart. So very good. All right. Everyone look at this EKG and tell me what sticks out to you as different. Well, first of all, let me ask you a question. Well, you know what? No, that's the first one I want to know. What seems abnormal to you? Very good, very good. So something is weird right around here, right? I circled too much. Like right in this region, something is very weird, right? So this looks like a very, would you say that this looks very wide to you? Yes, I would say it looks very wide. Would you say it has a very bizarre appearance? Yes. So what I have circled here is called a premature ventricular contraction. Okay. A premature ventricular contraction is basically the ventricles contracted before they should have. That's why it's called a premature ventricular contraction. And it has a very wide and bizarre appearance. Okay. So I have a question for you. Is this still sinus rhythm? And guys, if everyone can reply in the chat, that way I can know if everyone's understanding what we're talking about. Okay, thank you. Okay. Yes, absolutely. This is still sinus rhythm because in the others there's still a P wave in front of every QRS. The QRSs are the same distance apart. So what's the heart rate here? Very good. 60. So I would call this sinus rhythm with a PVC. Okay. So I wouldn't say normal sinus rhythm. I would not. I would not say normal sinus rhythm because the PVC is there, so it's not normal. I would just say sinus rhythm. And sinus rhythm is letting you know there's a P wave in front of every QRS. So because there's a P wave in front of every QRS, this rhythm is originating from the SA node. So it's a sinus rhythm. Um, and the heart rate is, sinus because it's within 60 to 100, but it just has an abnormality with the PVC. Okay. And as a nurse, you get more concerned when the PVCs come closer and closer together. What electrolyte should you check if you start to notice more frequent PVCs in your patient's EKG? Potassium, very good. So is the potassium too high or too low? It's too low. Very good. And so now I have a question for you. This is a common NCLEX situation. So let's say the patient has PVCs on their EKG. Does that automatically mean they have low potassium, or do you still have to check the blood level? Check the blood level. Very good. All right. So now we're going to learn there's three types of PVC frequencies. So you have ventricular bigeminy, ventricular trigeminy, and ventricular quadgeminy. Okay, so what you have to do to figure out these frequencies or to understand them is to look at this part. Hold on, get my underline tool. Look at this part, right? So bi means two. right? Very good. So bi means two. So let me type it for you. Okay, so to figure out, like, okay, ventricular bigeminy, like, what does that mean? So just think bi means two, so that means the PVC is always number two. So you're gonna have, like here, a normal heartbeat, PVC, normal heartbeat, PVC, normal heartbeat, PVC, normal heartbeat, PVC. Okay, so that's ventricular bigeminy. All right, so this is very concerning because it's not just like one random PVC out of nowhere and you don't see it anymore. No, this is at a point where the PVCs are now every other heartbeat. So that means this patient is at severe risk for electrolyte imbalance, for low potassium. Also, the closer that PVCs come together, the more likely it's going to turn into VTAC. Because when three PVCs happen continuously, that is the definition of ventricular tachycardia. Okay, so premature ventricular contractions, three premature ventricular contractions back to back mean that the patient has ventricular tachycardia. Okay, we would call that 3 beats of VTAC. So, does everyone understand ventricular bigeminy? That the bi means two, and so that means that the PVC is always number two. Okay, all right. Now let's look at ventricular trigeminy. So tri means three. So that means the PVC is number three. So that means you have two normal heartbeats and then a PVC. Two normal heartbeats and then a PVC. Okay? And so sometimes the first PVC or the first heartbeats get cut off. So you might have to look at the second PVC so that you can see one, two, the PVC is number three. 1, 2, the PVC is number three. 1, 2, the PVC is number three. So because the PVC is number three, that's ventricular trigeminy. Okay. Then we have ventricular quadreminy, which is, so quad means four. So that means the PVC is number four. Okay. So remember, sometimes you have to look at the second PVC because the first PVC, the normal heartbeats get cut off, right? Because this one here, it looks like ventricular bigeminy, but when you look, you're going to see normal heartbeat, normal heartbeat, normal heartbeat. So 1, 2, 3, the PVC is number four. So that's ventricular quadreminy. Okay? So we would say this is still a sinus rhythm, but we would say, well, technically 1, 2, 3, 4, 5. You can say sinus Brady. You can say sinus Brady with ventricular quadreminy. Okay? All right. So tell me, what PVC frequency is this one that's on the screen? Very good. This is ventricular trigeminy because it's number three. So 1, 2, PVC is number three. 1, 2, PVC is number three. 1, 2, PVC is number three. So ventricular trigeminy. Very good. All right. So this is what we call 3 beats of VTAC, where you have 3 PVCs back to back. Okay? So when you have 3 consecutive PVCs in a row, we call that 3 beats of VTAC. So when PVCs start to happen more often and closer together and more consecutively, the patient is running the risk of going into ventricular tachycardia. And we don't want that because ventricular tachycardia is fatal. It can be life-threatening. So that's why as a nurse, when a patient is on a heart monitor, we monitor that EKG rhythm often, and depending on the floor that they're on. If they're med-surg, it should be minimum every 4 hours, PCU minimum every 2 hours, ICU minimum every hour, and that's going to be more frequent if the patient has a problem with their heart. So you might have to be monitoring their EKG every 15 minutes, every 10 minutes, depending on what's going on with the patient. So you have to be able to recognize these abnormalities so that you can step in and perform the appropriate interventions to improve your patient's outcome. All right, the next thing we're going to learn is the difference between, so there's 2 ways to classify PVCs based on where they come from. And where they come from in the heart is going to determine what they look like. Remember, we talked about irritable foci? What did we say about irritable foci last week? Let me see who remembers. What are irritable foci? And what is so important about them? So we said that irritable foci are irritated areas of the heart where like an abnormal electrical impulse occurs. So let me show you. So we've seen pictures similar to this, but you know your electrical conduction system of the heart. First, it begins in the SA node, then to the AV node, to the bundle of His. It splits to the left and right bundle branches and up through the Purkinje fibers. But here we have an ectopic foci, or sometimes we call it an irritable foci. Okay, so ectopic means it's in the wrong place, right? Just like ectopic pregnancy, the egg was fertilized in the wrong place and it's dangerous. Ectopic means it's in the wrong area. So this is a patch of heart muscle cells that for some reason are irritated, and it could be because of electrolyte abnormalities, because remember we always say that when potassium is out of balance or any electrolyte is out of balance, it can irritate the muscle cells, and it can lead to the generation of an abnormal electrical impulse. And this can take over the conduction system and cause an abnormal heart rhythm. Okay, so as you can see, here we have the ectopic foci, and it's causing these electrical conductions to go up through the Purkinje fibers, and that's what could be the beginning of ventricular tachycardia and ventricular fibrillation. Okay, and it would take over, and you would lose the P wave because this abnormal conduction is not going up, and so you would lose the P wave on the EKG, and you're just going to have either consecutive PVCs, ventricular tachycardia, ventricular fibrillation, and eventual cardiac death, because this would not sustain the type of electrical conduction we need to have appropriate cardiac output that aligns with survival. Okay? So back to this, so you can determine where an electrical impulse came from that generated a PVC based on what it looks like. So there's two PVCs here. Here and here. So because they look the same, these are what we call unifocal PVCs. Because they look the same, they come from the same place. Okay? Everyone, my dear friends, if you can put your real name on the screen. Put your real name on the screen so I can see. Thank you, Prophetess Maylene. Thank you, Mr. Jean. Thank you, Miss Thanael. Thank you, Miss Erlene. If everyone can put their real name on the screen. Thank you, Miss Luna. Thank you, Miss Fracina. Everyone, please put your real name on the screen because there's two people that it just says iPhone. Okay. So when the PVCs all look the same, these are called unifocal PVCs because they came from the same irritable foci. Unifocal, they come from the same irritable foci. Okay. There's two people that their name is iPhone. So please put your correct name. Next up is multifocal PVCs. Multifocal PVCs, so we can see the two PVCs here, they have arrows pointing at them, but they look different. So that means they came from two different areas of the heart. So two different foci. So that's why it's called multifocal. It came from two different places. So when the PVCs look the same, that is unifocal PVCs. When the PVCs look different, we call that multifocal PVCs. Thank you, Miss Frislane. So if I don't say your name, you have to change your name in to put your correct name. So if I don't say your name is not showing and you need to put your name. Miss Frislane, Miss Maylene, Miss Fracina, Miss Luna, Miss Erlene, Mr. Jean, Miss Thanael. So if I just said your name, you are fine. If I did not say your name is not showing up and it just says iPhone and you need to put your correct name. Okay? So what would we call this rhythm? So 1, 2, 3, 4, 5, 6. So we would call this sinus rhythm with multifocal PVCs. Does that make sense? All right, guys. So let's take a short 5-minute break. And when we come back, we are going to learn about the other rhythms, including ventricular tachycardia and a special type of ventricular tachycardia. And we're going to learn the difference between monomorphic tachycardia and polymorphic tachycardia. And then we're going to get into ventricular fibrillation, asystole, and pulseless electrical activity. Thank you so much and see you in 5 minutes. All right, everyone. So still someone is named iPhone. So I'm just gonna put them in the waiting room. Okay. All right. So now we're going to switch gears and get into the lethal rhythms. Okay. Can someone, and we're just learning here, but can someone tell me what they think this rhythm is? Close. Oh, wow. Okay. So we've got some good choices. We've got some good choices. So some of you said ventricular fibrillation. Someone said SVT. Someone says torsades de pointe. Very good. This is torsades de pointe. So this is what we call a twisting of the points. It looks just like a party streamer. Okay, so we're going to talk about this. This is a type of ventricular tachycardia. Okay, so this is what we call polymorphic tachycardia. So we're going to learn the difference between polymorphic versus monomorphic ventricular tachycardia. So let's look at some pictures. Okay, and this picture is a little blurry, but I love this picture so much. I've been using it for years to teach this. So here we have torsades de pointe. So you can see it's big and then it gets tiny and then big and then tiny and then big. So when it gets big and tiny, it looks like a party streamer and it looks like it's twisting here at the point. So that's why it's called torsades de pointe. Okay. And then also just to show you, this is another picture to show you. It twists like a party streamer. Okay. And here we have a picture to help you to see the difference between monomorphic and polymorphic ventricular tachycardia. So ventricular tachycardia it looks just like mountains. So write that down. Ventricular tachycardia looks like mountains. So monomorphic tachycardia, mono, right? It has the same appearance. Polymorphic, it has a more chaotic appearance, okay? So now let's go back. So Torsades de Pointes is a type of ventricular tachycardia. So is Torsades de Pointes polymorphic VTach or is it monomorphic VTach? It is polymorphic. Very good. So Torsades de Pointes is a polymorphic ventricular tachycardia that can develop into ventricular fibrillation. Make sure you know the primary treatment is magnesium IV. Okay? Next up is ventricular tachycardia just in general. So Torsades de Pointes is a specific type of VTach, but now we're talking about VTach in general. So what you see on the screen here, is this monomorphic VTach or polymorphic? Monomorphic, very good. So to me, VTach looks like mountains. And I tell myself, oh my gosh, I would get tachycardia climbing all the way up this mountain and back down, and then all the way up this mountain and then back down. To me, VTach looks like straight mountains. So write that down. Also, write this down. Your number one priority with ventricular tachycardia is to check for a pulse. If the patient has a pulse, we give amiodarone. If they do not have a pulse, this is what we call pulseless VTach. Both are an emergency, but the patient will die if we do not defibrillate them. Every minute that goes by that we do not defibrillate pulseless VTach, the patient reduces their likelihood of 10% of coming back to life. Every minute that goes by. So, when you see ventricular tachycardia on the EKG, what is the first thing you are going to check for? A pulse. If they have a pulse, what is the medication you're going to give the patient? Amiodarone. If they do not have a pulse, what is the number one priority? Not CPR, defibrillation. Okay? Now, you know what? And let's talk about that. So, let's say you get a question on the NCLEX that you see ventricular tachycardia on the EKG, and then you check for a pulse and the patient has no pulse. We know that the treatment for pulseless VTach, we know that the patient with pulseless VTach, we have to defibrillate them. We know that. The number one priority is to get the defibrillator so we can shock the patient. However, is the defibrillator usually in the room? No. So while you wait for the defibrillator to get there, you can initiate CPR. But that's not going to save the patient. What's going to save the patient is defibrillating them. So I'm going to say it one more time. Ventricular tachycardia, there's two types, monomorphic and polymorphic. Monomorphic, it all looks the same. It looks like straight mountains. Polymorphic is a little bit more disorganized, like Torsades de Pointe, okay? But it still looks like mountains, okay? So ventricular tachycardia, your number one priority is to check for a pulse. If the patient has a pulse, we give amiodarone. If the patient does not have a pulse, you have to know that that is called pulseless ventricular tachycardia, and the number one priority is to defibrillate the patient. Every minute that goes by that you do not defibrillate the patient, your patient loses a 10% chance of surviving. So that means 1 minute goes by, you don't defibrillate pulseless VTach, now they only have a 90% chance of coming back. 2 minutes go by, they only have an 80% chance. 3 minutes, a 70% chance of coming back to life. 6 minutes go by, 40% chance. So and each minute that goes by, they're losing the likelihood of coming back. Remember, ventricular tachycardia is a lethal heart rhythm. When a patient has VTach and no pulse, they are dead. They have no pulse. They are dead. The only way to bring them back to life is to defibrillate them. However, while you wait for the defibrillator to get there, you can do CPR. But remember, that's not what's going to save the patient. The defibrillator will. Okay? Is everyone okay with VTach? Okay. Next up is ventricular fibrillation. So this is also a lethal rhythm. Remember, pulseless VTach is lethal, ventricular fibrillation is lethal. So this is ventricular fibrillation, okay? So remember I told you whenever you see fibrillation, I want you to think scribillation. This looks like scribbles, right? This looks like scribbles, like you gave a toddler a pencil and they just drew on it, okay? Your number one priority is defibrillation. So ladies and gentlemen, your most important rhythms on the NCLEX are the ones that can kill patients. Ventricular tachycardia, ventricular fibrillation. You have to know ventricular tachycardia without a pulse is called pulseless VTach. Defibrillation is the treatment. Ventricular fibrillation, defibrillation. For VFib, you defib. Okay? So please write this down. Please memorize this. Please write this down and please memorize this. When to shock a patient. When to defibrillate. These are the only two rhythms that we defibrillate. Pulseless VTach and VFib. Okay. All right. Now we're going to talk about what is the difference between cardioversion and defibrillation. So I want you to write this down. And guys, I'm telling you, cardiac is the most important topic on NCLEX, so you don't want to neglect this topic, okay? Okay, so write that down. You cardiovert the living, you defibrillate the dead. So let's look at this picture to see what is the difference between cardioversion and defibrillation. Okay, so first off, let's look at the patients. So in the section for cardioversion, what is the patient doing? What does the patient look like? Is the patient awake in the cardioversion section? Yes, he looks awake. He's even smiling, right? The patient might not always be smiling if they need to get cardioverted, but he's awake. He's alive. What about the defibrillation section? How does that patient look like? Someone said bad. Does that patient in the defibrillation section, does that patient even look alive? No, they don't look alive. They look dead, right? So there's your first difference. You cardiovert the living, you defibrillate the dead. Remember the two lethal rhythms we learned about that you defibrillate are pulseless VTach and VFib. Those are the only two rhythms that you defibrillate. And so that means when a patient has pulseless VTach or ventricular tachycardia, they are dead. They are dead. And the only way to bring them back is to defibrillate them. The longer you wait, the less of a chance your patient has to come back to life. And I know I keep repeating myself, but it's so important because we are responsible for saving lives. Every minute that goes by that you do not defibrillate pulseless VTach or VFib, your patient loses a 10% chance of coming back to life. You have to know how to recognize VFib and pulseless VTach, and you have to know how to defibrillate them. So you cardiovert the living, you defibrillate the dead. Let's look at the nurses. So in cardioversion, the patient is alive. Defibrillation, the patient is dead. Let's look at the nurses. The nurse for cardioversion, how does she look? Is the nurse smiling? The nurse up at the top for cardioversion, she's smiling, right? Does she look kind of calm? She's kind of chilling. She's looking at the informed consent. You know, she's like, yeah, I'm about to go cardiovert this patient that's an SVT. You know, another day, another dollar. You know, she looks fine. What about the nurse for defibrillation? How does she look? The nurse for defibrillation, she looks stressed. She looks like she's calling on Jesus. Like, Jesus, my patient is dead. Please help me. Okay? So that is because defibrillation is more of an emergency. It is an emergency. So cardioversion is elective. Elective means the patient can say yes or no to it. The patient signs the informed consent. We sedate the patient and we cardiovert them. It's not as an emergent situation as defibrillation. On the other hand, this patient is dead and we have seconds to minutes to save this patient's life. Okay. Also, cardioversion is synchronized with the QRS. So that means we deliver the shock on the R wave. Okay. Defibrillation is not synchronized. Okay, so that's why here it says cardioversion sync on, defibrillation sync is off. Okay, so let me pull up a picture so I can show you. So this is what we call synchronized cardioversion. So you use the same machine. Um,
Hello.
you use the same machine that you would use for defibrillation. However, we're using a lower level of energy, okay? And also we're synchronizing it with the R wave. So do you see the white arrows on the EKG? Let me know, guys, if you see the white arrows. Oh my gosh, look at this patient's heart rate. Lord. What's the patient's heart rate? 227. Oh my gosh. Like, they must feel palpitations like crazy, right? Oh, I would not want to know what that feels like. That probably feels like their heart's going to pop out of their chest. And what rhythm is this? It's definitely not sinus. No, that's not VTAC because you can clearly see the QRS complexes. VTAC is just mountains. That's SVT. There we go, right? Because remember, VTAC is mountains, right? SVT is like you see it's very skinny and you lost the P wave, right? So very good. And so what medication would we give to help treat this patient? Adenosine, very good. And then if the adenosine did not work, then we would jump to cardioversion. So cardioversion, you synchronize it with the R. So because you see, this is the QRS. So QRS. So the white arrows will show up on the R wave and you're going to shock them right on the R wave. So you wait for one to finish, and then as this one is coming up, you shock it. You shock the patient. So it's like it's coming up here, shock them on the R wave. And so that's why it's called synchronized cardioversion because it's synchronized with the R wave. That is when the shock is delivered. So now let's go back. So that's why I say it says sync on. And let me show you just one more picture. Hold on. There we go. This is what I'm looking for. Hold on. Okay, so some pictures just for us to look at. So this is another defibrillator. It's a Medtronic. Um, and here you see they have the recommended adult VFib dose is 200 to 300, up to 360 joules. So that's for VFib. And so that's for defibrillation. But we can use this for synchronized cardioversion. So we would, if we're going to use this for cardioversion, we would press this button here that says sync. You see? So what you would do is you put the pads on the patient, and I'm going to show you how. You put the pads on the patient, you turn this on, Then you select the energy, okay? Cardioversion is usually 50 to 200 joules. So you see the difference? So cardioversion, and it's on the screen. So cardioversion is usually 50 to 200 joules. VFib for defibrillation, you start at 200 joules up to 360 joules of energy. So do you see the difference? Cardioversion, you use much less energy to shock the patient. So someone asked, if BP is low and the heart rate is high, can you still do cardioversion? Well, it depends. You know, why are we doing cardioversion? Cardioversion is for SVT, it's for AFib, it's for A-flutter. So remember, cardioversion is elective. Cardioversion is not usually like emergency. So it's usually like, okay, we tried the meds aren't working, let's try the cardioversion. So if the healthcare provider felt that we needed to fix the blood pressure first, we can fix the blood pressure and then cardiovert. However, if the blood pressure is low because the heart rhythm is so, bad, like SVT or something, then we could still cardiovert in an effort to improve cardiac output by normalizing the heart rhythm. Okay. But I don't think it would be a problem. I don't think it would be a problem because the blood pressure is probably low because of the bad rhythm. So if we cardiovert them and get them back to sinus rhythm, we can fix it. And we could give them fluids, we could give them vasopressors, but that's the thing you have to remember. Cardioversion is not like an emergency like defibrillation is. Okay, so it's elective. The healthcare provider can kind of choose when it's time to implement it versus defibrillation. When it's time to do it, it's time to do it now. So you connect the patient to the monitor with the pads. You turn it on, you select the energy. Cardioversion is 50 to 200 joules of energy. And then make sure sync mode is on. You charge it, and then you're going to synchronize it on the R, and you deliver the shock on the R. And that is synchronized cardioversion. Here's a close-up picture of the sync button. And then here's in another, like the first picture we looked at, here you can choose, it's touch screen, you can choose sync on or off, and they're delivering 100 joules of energy. Okay. So again, cardioversion is elective. The patient is awake. You cardiovert the living. They're awake and sedated. You synchronize it with the R of the QRS. You deliver 50 to 200 joules of energy. The patient signs the consent form. They're on the EKG monitor. Versus defibrillation, this is emergency. The patient is dead, and they're going to stay dead if you don't defibrillate them right away. This is for VFib and pulseless VTach. The patient has no cardiac output. They are dead. You have to defibrillate them. You begin with 200 joules and you can go up to 360. And the patient is on the EKG monitor. Okay. This is another table. It's everything we just talked about, but it's just in a table format. Okay. So that is cardioversion versus defibrillation. What are the two EKG rhythms that you defibrillate? Or the only two rhythms that you defibrillate? Very good. But is it just VTach or is it a specific type of VTach? Which, yes, pulseless VTach. Very good. VTach without a pulse. Pulseless VTach and VFib, you defib. Okay. All right. And then for cardioversion, you can cardiovert SVT. So you can cardiovert supraventricular tachycardia, you can cardiovert AFib, you can cardiovert A flutter. Okay? So you cardiovert SVT, AFib, A flutter, you defibrillate pulseless VTach and VFib. So memorize that for your NCLEX. So defibrillation, a dose of electric current is given to countershock the electrical activity of the heart in hopes of establishing normal sinus rhythm. You place the pads on the high right, low left. Memorize that for NCLEX. High right, low left. You defibrillate 200 to 360 joules. So this is what we call an automated external defibrillator. You find these like at a school cafeteria or gym, like in public places. So this is a defibrillator. It's automated because it talks to you. So we're going to watch a video that's going to show you. It talks to you and tells you what to do. It tells you to get the pads, to put the pads on the patient. It has pictures on it, and the picture shows you high right, low left, high right, low left, right? And when you turn it on, it's going to tell you analyzing heart rhythm, do not touch patient, shock advised, charging, do not touch patient, press shock button, right? So this is automated. It talks to you. This is for public places. Okay? What we use in the hospital is a manual defibrillator. Okay? It doesn't talk to you. You got to know what to do on your own. Because if you're able to use this, you've done ACLS, CPR. Okay? So you turn it on here. Okay, so if you move the dial here, it's off. If you turn it on here, it's on. Pacer mode is like transcutaneous pacing for symptomatic bradycardia that didn't respond to atropine. And it does have an AED mode. I lied. It does have an AED mode, but as nurses, we don't use that because we receive the training on how to use this. Okay. You turn the dial here to charge for the joules. Here is the sync mode. If you press that, these arrows are going to show up on the R of the QRS complex so that if you have to cardiovert the patient, you can cardiovert them. So you see how the line is moving here? It's making the new EKG. So as the line is moving, when it gets to here, and as it gets here to the Q, you give the shock right on the R. Okay, so that would be synchronized cardioversion. For defibrillation, you would turn up the joules. Okay. And then you have 1, 2, 3. Okay, so you would select the energy level, you would charge it, and when you press charge, as you press charge, once it's done charging, before you press the shock button, you have to say clear. No one can be touching the patient. No one can touch the patient. Because if you deliver the shock and someone is touching the patient, now that person who got the shock on accident is going to have to go to the emergency room. Okay. I've seen a man, I wasn't in the room. He told me about it after. But they were in a code, and this man is like 6'4", 200 pounds, very muscular. He was helping out in a code, and he was touching the foot of the patient. The nurse who was handling the defibrillator, she didn't yell clear. She delivered the shock, and because he was touching the patient just a little bit, he had to go to the emergency room because he had chest pain, because he got shocked. And he's big, very big, looked like a wrestler. So imagine, a normal person. You don't want to end up with 2 patients, okay? Also, here is a timer. from when you turn it on, the timer starts. So that helps you because when you're running a code, someone has to be the recorder, okay? And here you have the heart rate, and here you have the pulse ox, okay? If they are connected to the pulse ox. So we learned about automated external defibrillator, the public ones. We learned about manual defibrillators, which is what we use in the hospital. So one thing about both of these defibrillators, the manual and the AED, these are external, right? We're putting pads on the patient, turning on the machine, and we go from there. But now we have an internal defibrillator, one that is surgically implanted. We call this an automated implantable cardioverter defibrillator. So it can cardiovert SVT, AFib, and AFlutter. It can defibrillate pulseless VTach and VFib. It can also work as a pacemaker, okay? So I just wanted you to know that there's different types of defibrillators, okay? Our next lethal rhythm is asystole, which we call a flat line. This is a lethal rhythm. This patient is dead, and they will stay that way if you don't do CPR, okay? And in doing that CPR, you're going to try to figure out what could have contributed to them having this rhythm, okay? So make sure you know for asystole, there is no rhythm. You see no movement here. It's a flat line. There's no EKG rhythm. The patient has no pulse. There is no cardiac output. Not one drop of blood is leaving the heart. So therefore, we have to do CPR to compress the heart and give them oxygen through the respirations so that we can circulate oxygenated blood in their body while we're trying to figure out what led them to this point, okay? And how do we figure out what led them to this point? We do what is called the H's and T's. So let me pull that up for you. Oh, I love this picture so much. I've been using it for years, okay? So this is for any patient who's coding. Any patient, whether they have pulseless VTach, VFib, asystole, PEA, whatever, if their heart has stopped, we want to figure out while we're doing CPR. So, Miss First Lane asked a question. She says she wants to know if you give epinephrine first and then atropine. So atropine is specifically for symptomatic bradycardia. So you would not be giving atropine for asystole. Atropine is for symptomatic bradycardia. Epinephrine is for the other rhythms like VTach, VFib, asystole, and PEA. Okay, so those are two different routes of treatment, two different conditions altogether. Okay, so any patient who's in cardiac arrest while we're doing CPR, because we do it as a team, when we're running a code, you have someone who's responsible for doing compressions. You have responsible for someone for airway and respiration. You have someone responsible for getting IV in and giving the medications. You have someone responsible for running the defibrillator. You have someone responsible for recording everything that happens, the time the code started, what medication is given, how much medication is given, where was it given, the time, the dose it was given, when did compression start, when did we stop to do a pulse check, when we did the pulse check, was there a pulse, what does the EKG say? Okay, then you have a leader. The leader runs the code. Okay, usually when you work PCU, ICU, based off of the nurse assignment, they already assign the members of the code team so that you know if you have a code that day, you know that you're recorder or leader. Usually the leader is either the charge nurse, the nurse supervisor, or the healthcare provider. Okay, so while we're doing CPR, we're working together as a team to effectively, do the CPR. However, we're talking together to try to figure out what could have caused this, and we call it the H's and T's. Hypovolemia, hypoxia, acidosis, which is because of hydrogen ions. Is it hyper or hypokalemia? Hypothermia, hypoglycemia. Was it some type of toxin or overdose of tablets or medication? Is it cardiac tamponade, tension pneumothorax, thrombosis, thromboembolism, or trauma? So these are all common causes of why someone's heart would stop. So once we identify what it is, we can properly treat the patient. Okay. For example, one code I was in, it was because the patient is a dialysis patient and they were in severe metabolic acidosis. And so they were coding. So while we were doing CPR, we were working along with the doctor. And once the doctor, we did an ABG while we were doing CPR. And we found out that they had metabolic acidosis. So to reverse acidosis, we have to give a base. So we gave the patient sodium bicarbonate and they came back to life in 30 seconds. Okay. So, and then toxins, I was doing a code one time and it was because the patient got too much narcotic. So I gave the patient naloxone. They came back to life in 15 seconds. Okay, so it could be you have a diabetic patient and their blood sugar is very low, so their heart has stopped. So once we check the blood sugar, as we're doing the code, because somebody can be doing compressions in airway, and another team member get the patient's finger and check the blood sugar, and then we see, oh, the blood sugar is 28. Okay, so now we're gonna push D5 or D10. Okay. All right, so let's go back. So asystole, asystole, this patient has no pulse. So we do CPR, okay? The treatment for asystole is CPR, and you always start with compressions first. Next up is pulseless electrical activity. This is another lethal rhythm, okay? She's a liar. Write this down. PEA, she's such a liar. Oh my gosh. PEA, she is such a liar. Do you want to know why? PEA, she's such a liar. You see an EKG rhythm on the monitor, but it's fake. The patient really has no cardiac activity going on. That's why it's called pulseless electrical activity. The patient has an EKG rhythm on the monitor, but it's a lie because if you check the patient's pulse, they have no pulse. PEA. She's such a liar, man. Okay. Everyone with me so far. So let's go over some basics again. So for VTAC, you want to check for a pulse. For VTAC, if they have a pulse, you give amiodarone. If they do not have a pulse, that's pulseless VTAC, you defibrillate. Ventricular fibrillation, you defibrillate. Asystole, you do CPR. Pulseless electrical activity, you do CPR. Everyone okay? Okay. So, when to shock, the only shockable rhythms are pulseless VTAC and VFib. Non-shockable rhythm, you have to do CPR, is pulseless electrical activity and asystole. Let me give you a moment to write this down in your notes and then we will continue. All right, guys. So I'm gonna load up the videos. We're gonna watch a couple of videos on CPR and how do we do CPR outside of the hospital versus how we do it in the hospital with a team. So let's take a 5-minute break, and when we get back, we're gonna learn how to do CPR, all of the steps, and then we're gonna continue on in learning how to save patients' lives when they are in a cardiac emergency. Thank you so much. All right, everyone, so we're going to watch a couple of videos. So this first video is going to show you how to use an automated external defibrillator. Remember, those are the ones that talk to you that you're going to find like in public places, okay? All right, here we go.
When a person is in cardiac arrest, early use of an AED can help restore a normal heartbeat. For each minute CPR and defibrillation are delayed, a person's chance of survival decreases by 7 to 10%.
An AED is simple to use. Just turn it on and follow the prompts.
If you are the only trained responder on the scene, turn on the AED as soon as it is available and follow the voice prompts.
Attach pads firmly to person's bare chest as shown.
Remove all clothing covering the chest to place the AED pads and wipe the chest dry if necessary. First, always use adult AED pads on anyone older than 8 years of age and or weighing more than 55 pounds or 25 kilograms. Do not use pediatric AED pads because the shock delivered will not be sufficient. Then, place one pad on the upper right side of the chest. And the other on the lower left side of the chest, a few inches below the left armpit. Follow the diagrams and labeling of where each pad goes. If the AED pad has a feedback device, follow the manufacturer's instructions for use.
Plug-in connector.
Plug the pad connector cable into the AED if necessary and prepare to let the AED analyze the heart's rhythm. Make sure no one, including you, is touching the person. Say clear in a loud, commanding voice.
Don't touch person. Analyzing.
Clear. Be ready to deliver a shock if the AED determines one is needed.
Shock advised. Press flashing shock button.
Again, make sure no one, including you, is touching the person and say clear in a loud, commanding voice. Clear. Push the shock button to deliver a shock and immediately start CPR, beginning with compressions.
Shock delivered. Start
1
CPR.
and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9. You should continue giving CPR cycles until you notice an obvious sign of life, like breathing. The AED prompts you to analyze again. Another trained responder is available to take over compressions. EMS personnel arrive and begin their care of the person. You are alone and too tired to continue, or the scene becomes unsafe.
Who's coming in the driveway?
Okay, so that was the AED. And I'm going to send all of these videos in the WhatsApp, okay? So now this is going to show you what CPR does inside the body, okay?
Is an amazing organ. It works hard for us every second of every day, delivering blood and oxygen to every cell in our body. But when sudden cardiac arrest strikes, our heart suddenly and unexpectedly stops beating effectively and blood flow stops. Without any intervention, the brain, vital organs, and our heart will begin to die. Beginning CPR is the person's only chance of survival. Brain damage will start to set in within 4 minutes, and after 10 minutes, brain damage becomes irreversible. The power to save a life is truly in your hands. Performing CPR accomplishes 2 critical things. 1, compressions move oxygenated blood to the brain to keep the brain alive. And 2, compressions keep blood and oxygen moving to the heart muscle itself, so that it has the best chance of resuming a normal electrical rhythm after a shock is delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, So it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is necessary to keep blood pumping. Let's see what happens when we take our hands off the chest. Blood stops moving to the brain. It is for this reason that if you are taking your hands off the chest to deliver breaths or switching roles, it is critical to minimize time off the chest. Watch what happens when we don't push deep enough. Blood does not reach the brain. The same is true if we do not push fast enough. Watch what happens when we push too fast. The heart does not have time to refill with blood, therefore not enough blood gets pumped out. Watch what happens when we don't allow the body to decompress and allow the chest to fully recoil. The heart does not have a chance to refill with blood, therefore no blood gets pumped out. So remember, the key purpose of delivering compressions is to keep oxygenated blood moving within the heart and up to the brain to keep the brain alive. We need to push hard and push fast in the center of the chest. If ribs break, that's okay. What's not okay is allowing the brain to die from a lack of oxygen. So remember, you are their only hope. Do the best you can, and don't give up until medical help arrives or an AED is present. You can do it.
CRM is so
All right, guys, this is how we do CPR in the hospital. So what you saw in the first video, you saw how we do it outside of the hospital when we don't have like IV pumps and manual defibrillators and heart monitors, right? But in the hospital, we have all of the equipment, we have more help. So you're gonna see how it works, okay? In the hospital.
This is a quick demonstration of this pit crew CPR model. The first person who recognizes the cardiac arrest calls for help, calls the code, and then starts manual compressions. One difference we're implementing at the recommendation of the Minnesota Resuscitation Consortium, which is part of the National Heart Rescue Project, is to do continuous chest compressions in all patients, even if they do not have an advanced airway. So no more 30-2. Second person gets there and starts ventilating the patient with the rescue pod. And be sure you follow the timing lights and don't hyperventilate the patient. One hand squeeze of the ambu bag every time the timing light goes off on the rescue pod. If a second person or third person arrives, you should try to do two-handed face mask seal to get the best seal possible. So one person bags and the other one does a two-handed face mask seal. Additional person comes into the room and operates the monitor and defibrillator, so gets pads on the patient and gets ready to defibrillate. You want to rotate manual CPR every 2 minutes or every 200 chest compressions. Be sure to allow full chest recoil to maximize the negative pressure in the chest on the upstroke, which ensues or brings more blood back to the heart.
Ready? Ready.
Here they're putting the backboard on for better resistance for chest compressions. This next video demonstrates when the code team comes, how you transition over to that. So a quick report will be done, code leader gets identified, and the code team members will take over compressions, monitor, and airway.
We're in asystole. Okay, switch chest compressions. We've got someone on the defibrillator.
Yep.
Okay. And Pharmacy is on their way.
This is a demonstration on how to transition from manual CPR to Lucas CPR. Remember, chest compression interruptions less than 10 seconds for any maneuver. And we found that with a patient in the bed, it's easier to lift them up to put the Lucas backboard on rather than to log roll them. Chest compressions continue as the Lucas backboard is placed. Then Lucas is placed really through the arms of the person doing manual CPR and attached, and then it is turned on, plunger lowered in place, and Lucas starts. As you'll note, each interruption of chest compressions was less than 7 seconds in this demonstration. So that's how to transition from manual to Lucas CPR. Thank you.
Okay. And remember, I'm going to
Alright,
post
you guys,
these
welcome back.
videos for you. And this last one is going to be how you use an AED. And he's also going to demonstrate it on a child, okay?
Start grabbing an AED, you just pull up in the door. Oftentimes, to first start grabbing an AED, you just pull up in the door. Oftentimes there will be a loud alarm associated with it. Turn the device on. It's going to talk to you in a loud voice, and it's going to tell you what to do.
Unit OK. Adult pads. Remove pad package.
And it will tell you where to place the pads. Take the pads out of the packaging. You'll see displayed where to place each pad. Undo the back of the pad.
Attach pads to patient's bare chest.
I'm placing this pad in the right upper hand side of the chest with the centerpiece over the breastbone. Then, with that in place, I take the other pad, take the sticky off, and again, following the diagram, this is then going to fold over onto the lower left hand side of the chest. If the device tells you that a shock needs to occur, have everyone stay clear of the patient, don't touch the patient, and press the shock button on the device. When you press that button, it will deliver a shock. When it is analyzing the rhythm, you would hear something like this.
Stay clear of patient. Analyzing. Shock advised. Stay clear of patient. Deliver shock now.
So in this case, then you would press the button to deliver the shock, making sure that no one is touching the patient, and then that way you stay clear of getting shocked yourself.
Shock delivered.
You press the device.
Begin CPR.
It delivers the shock, and then again afterwards, if you know CPR, you can go back to doing CPR. This device provides the area where you should be doing CPR. This little circle with the diagram
Start CPR.
is where you can do CPR. So on this patient,
Push harder. Push harder. Good compressions.
this AED gives you feedback on your compressions to make sure you're doing it at a correct rate and a correct depth, which can be very helpful. And for this one, you would essentially follow the same steps as you would for the adult. You can use adult pads in a pinch if you need to by placing one side on the front of the chest and then the second pad on the rear of the chest. So that lights up if you have a pediatric pad. If you have access to pediatric pads and it's a pediatric patient, try to use those pads though, because when you plug those pads into the device, it tells the device that this is a child, and so it will change the amount of electrical shock that's delivered. Just use the adult if that's all you have access to. The device will determine an initial rhythm, and if it believes that a shock is needed, then it will tell you to give a shock. If the initial underlying rhythm does not need a shock, then the device will tell you to start CPR. There are a couple different ways to perform CPR in a child. we're going to be doing a 2-finger push into the chest like this. Another method is to grab the child around and use your thumbs. If you know how to perform pediatric CPR, then go ahead and do that. You'll do it for 2 minutes. The AED will tell you when to stop doing CPR and get your hands off the chest so that it can analyze the underlying rhythm. If a shock is advised, the AED will tell you to do it, and you'll deliver the shock by pressing the button as we went over. And then just like with the adults, after you deliver the shock and you know how to do CPR, then go ahead and continue to do CPR for the next 2 minutes.
Why waste another side?
All right, everyone. So those are the videos. I'm going to share those videos in the WhatsApp group. So now let's go over some important components for CPR. So when we're talking about someone who is a code blue, this is somebody who requires CPR, and we may not know what rhythm they have yet. We don't know if they have VTAC or VFib or asystole or pulseless electrical activity. All we know is that they are not breathing and they don't have a pulse. So make sure you know that. Someone who you call a code blue on, they're not breathing and they don't have a pulse. Anything outside of that we call a rapid response for, okay? So, first thing, you walk into your patient's room. If you suspect that something's wrong, for example, they're not looking at you when you talk to them, their eyes are closed, you don't see their chest rising and falling, you're going to assess for breathing and a pulse. You have 10 seconds max to do this. For an adult, you check the carotid pulse in the neck. For a child, you check the brachial in the middle of the upper arm. You have 10 seconds max to check if they're breathing and have a pulse. For breathing, you can look and see if their chest is rising and falling. Remember, in children, they usually breathe from their belly. Like babies usually breathe with their belly. But either way, look and see. Put your hand on their chest if you have to. If they're not breathing and don't have a pulse, you call a code blue so that help can come. CPR is extremely exhausting, and CPR requires a lot. It's very difficult for you to do everything on your own. It's impossible and it's irresponsible. You have to get help. Okay? That's why when you're outside of the hospital, the first thing you should do is call 911 or ask someone to call 911 because you need help to come. I'm telling you, compressions are exhausting. It's like it's exercise. So you're going to get tired, and as we get tired, the quality of our compressions diminish, and we have to give high quality compressions if we want the patient to come back to life. So remember, every patient, we have to care for them like our own family. So that's someone's family member. We want to give the best of what we can, and we need a team to give the best CPR. So after you call code blue, this patient is not breathing and they don't have a pulse, you need to start compressions immediately on a hard surface. So a soft mattress is not going to cut it. Usually the foot of the footboard comes off, and you can slide it under the patient's back. Okay? 30 compressions to 2 breaths. So you give 30 compressions, then you give 2 breaths. Then you give 30 compressions, and you give 2 breaths. You do this for 2 minutes. Okay? You give 30 compressions and then 2 breaths. 30 compressions and then 2 breaths. 30 compressions and then 2 breaths. You do that for a total of 2 minutes. When you're giving compressions, you want to push hard and you want to push fast. You want to give at least 100 compressions a minute. Why? When you give compressions, you're beating the patient's heart for them, and a normal heart rate is 60 to 100. So we want to give them at least 100 compressions a minute. For an adult, you push at least 2 inches deep. For a child, it's 1.5 inches deep. Breaths, as you give breaths, you want to look for chest rise. But you don't want to give breaths that are too forceful because you can push air in the stomach and cause the patient to vomit and aspirate. When help arrives, you apply the pads. Remember, high right, low left. You connect them to the defibrillator heart monitor. Turn it on. You stop and assess the rhythm because you want to know right away, do I need to shock this rhythm? Because you don't want minutes to go by and the patient is losing 10% chance of survival. So you assess it. If it's pulseless VTach or VFib, you're going to shock the patient. Make sure no one is touching the patient when you deliver that shock. You have to clearly yell out, clear. Do not touch the patient. Even touching the ambu bag or the oxygen that's on the patient, someone can get hurt. If it's asystole or pulseless electrical activity, you resume CPR. So you resume CPR in the fashion of 30 compressions to 2 breaths, and you keep doing that. And then every 2 minutes you stop, you're going to do a pulse and rhythm check every 2 minutes. You're going to check for a pulse, either the carotid or the femoral, and you're going to look at the monitor to see if they have a shockable rhythm. At any point, if it's a shockable rhythm, you shock them and then you immediately resume CPR. Epinephrine can be given every 3 minutes. And while we're doing CPR, you're thinking of the H's and T's. So someone should have already checked the blood sugar. We're going to do an I-stat. An I-stat is a very quick way. We're going to get potassium level, magnesium level. We're also going to get ABGs from the I-stat. Okay. Now, if you get a rhythm and you got a pulse, the patient has survived. Congratulations, you saved a life. Provide them with oxygen, give them IV Zofran, turn them on their side because they can be nauseous and throw up. And then you're going to check the rhythm. If it's ST elevation, you send them to the cath lab for cardiac cath. The reason they code it is because they had a heart attack and it stopped their heart. If there is no ST elevation, you send them to the ICU. Okay, so for homework, I really want you to study this, okay? You have to study this and you have to know this extremely, extremely well, okay? So that is it for today. We've learned a lot. So for homework, you have a lot of rhythms to memorize. Okay, you have to memorize supraventricular tachycardia, you have to memorize torsades de pointes, VTach, and you have polymorphic, monomorphic, you have VFib, you have asystole, you have pulseless electrical activity, you have ventricular bigeminy, trigeminy, and quadreminy, your multifocal versus your unifocal PVCs. You have a lot to study. So study those EKGs and know them well. Remember, for SVTs, you use adenosine, okay? For VTach with a pulse, you use amiodarone. And for any of the rhythms, the lethal rhythms like VTach, VFib, asystole, PEA, when we're doing CPR, we can give epinephrine every 3 minutes IV push. For torsades de pointes, the treatment is magnesium. Okay, and also I'm going to send you the videos of what we just watched for CPR. Watch them. So I really recommend you rewatch this recording when I post it. You read over your notes, you add more to your notes as you need, and you watch the videos that I send you so that you can be very strong in this. What are we going to do next week? Next week, we're going to learn about heart blocks. You have first-degree heart block, second-degree heart block type 1, and second-degree heart block type 2. You have third-degree heart block. We're going to learn about pacing. We're going to learn about pacemaker spikes, failure to capture, failure to sense, okay? And then we're going to get into cardiac diseases. We have to learn about coronary artery disease and how do you use CABG and PCI. You have to learn about hypertension. You have to learn about heart attack. You have to learn about pericarditis and cardiac tamponade. So we have a lot to learn. So we're definitely going to finish cardiac next class. However, you have to build a strong foundation this week and study what we reviewed. Okay, if you have a Q bank, go ahead and do 50 to 100 questions on cardiac to build you up. All right, everyone, I will post this recording as soon as it's done. Don't forget to go to my website, alexreview.com, and sign up for the NCLEX Practice Questions Live. It's going to be starting next week, Monday, and it's going to be every Monday from 8 to 10 p.m. So if you go to my website and you can go down, you can see I have the NCLEX Practice Questions Live, and you can share this with your friends. However, remember, you have a separate price. So you only have to pay $70 a month. So you can either do $20 a week or you can do $70 a month. And we're going to be doing questions every Monday from 8 to 10 p.m. So you can Zelle that to my number. You all have my number through the WhatsApp group, okay? Tell your friends to sign up for the review. They won't regret it. And tell them to go to the website. I'm going to be live on Facebook tonight at 9:30, and I'll post the link in the chat when I start. Thank you so much, everyone. Have a blessed day. Remember, you can do it, you can do it, you can do it. Your words are powerful. Whatever you put out into the earth, whatever you say with your mouth, you're putting out into the earth. So put out good things for your life, and you will see that you will achieve your dreams. God bless you and have a blessed day. Thank you.